responses and public health. Warm welcome back to those of you returning to the series. Some of you have been with us for all 4 sessions, so that's awesome to see our most dedicated fans and followers. And also, hello, warm hello to those of you joining for the first time. Excited to have you with us. This studio session series is co-presented by the UC San Diego Design Lab, Center for Human and User-Centered Design Research, Education, and Community, and the Visual Arts Speculative Design Program, a track within the Visual Arts Department that brings together art, media, and design futuring methods. This series responds to a number of inquiries that have been at the forefront of conversations within the Design Lab this year: how to design for the redistribution of power, how to design against privilege and bias, and how to support ethical responses to complex situations across scales. In the spirit of, this is a very interdisciplinary series and series of sessions, so we encourage you to be open to challenging some of your deepest held presumptions about good or bad, the right way to do things, what's possible or probable. For those of you who have requested closed captioning, you can click on the top of the screen on the live button, and you should see a new transcription pop up in a tab for you. It's important to note for those of you joining us that we're recording these sessions and we will be posting them to the Design Lab's website. Forgive us, we're doing a little bit of light editing and adding some slides. So for those of you eagerly waiting to see past sessions, don't worry, they will be up soon enough. I'm Stephanie Sherman. I've had the pleasure of co-producing this series with my fellow visual arts PhD candidate, Jonah Gray, under the curatorial leadership of Lisa Cartwright and by the instigation of the Design Lab's Camille Nebeker, who's our session presenter today. So we want to, again, thanks the Design Lab and Visual Arts Department and Speculative Design Program for their support. Okay, and on to a quick introduction of today's session and speaker. And the session is called Imagining the Ethical, Legal, and Social Implications of Digital Contact Tracing. Dr. Camille Nebeker is an associate professor in the School of Medicine at UCSD. Dr. Nebeker is affiliated with the divisions of Behavioral Medicine and Global Health in the Department of Family Medicine and Public Health. Her research focuses on the design of research bioethics educational initiatives designed for the traditional and non-traditional learners, with a goal of trainees' understanding and appreciation of factors that influence the ethical and responsible conduct of research. So aside from Camille, who's gonna first lecture and then we're gonna do a workshop, we're joined by 3 members of her team at Recode Health, Noah, Miriam, and Danya, and you will see them as the leaders and facilitators of your breakout sessions. All right, well, without further ado, I'll turn it over to you, Camille. Thanks so much to you and everyone for joining us today.
Thank you so much, Stephanie, for that nice introduction. Let me go ahead and share my screen. Let's see. Okay. So again, thanks so much for not only producing this series. I've learned so much from attending the prior workshops, and this was instigated actually by students in the Design Lab, and we were trying to figure out how to have fun with talking about ethics in our everyday lives. And so one of the suggestions was to do design fiction workshops, and that's really the origin of how we got to the place where we started to create these opportunities. I come from a public health background, and in teaching about scientific ethics, I often use use cases to help students understand the different kinds of things that happen in the research environment. And I know that design fictions are supposed to be things that might happen in the future, but in actuality, things that are happening today, I couldn't have envisioned them happening a year ago. And so right now we're in the middle of this pandemic. And there is an awful lot happening with the use of digital tools to help us think through how we can manage COVID. So what I'm going to start with is just some background on what what we mean by the use of health technologies, how they're being used in regular health research, but now how they're being used to help mitigate the spread of COVID, and not only mitigate the spread, but for use in identifying where COVID is in our actual campus environment. Just to kind of ground us, I use this term ELSI, which has its origin from the genomics community. And so when the National Institutes of Health allocated funding for the study of the human genome, they earmarked money for research on ethics because they knew how important it was to understand the ethical implications of people having access to knowing what kinds of genomic traits they had. And so I'm borrowing this acronym of ethical, legal, and social implications, and I've been applying it to the digital health research landscape for close to 8 years now. And so when we think about the ethics, the lane or bucket, I automatically think about our traditional ethical principles that are used to guide ethical and responsible research with human subjects. So those are respect for persons, which is demonstrated through the informed consent process. Bystander rights is something new because with a lot of these new technologies, people around the person that agrees to participate in research can have their information picked up either through microphones or through wearable cameras. We're in a place now where cameras are pretty much everywhere, and how the data that are being collected are used is something that we don't have a lot of really great regulations for or laws that guide how those are used. Beneficence is the principle of evaluating risk and benefit and trying to figure out how to mitigate risks while escalating potential benefits to human health. And I do focus on public health and biomedical and behavioral research in my work. So that's really how I anchor much of my thinking in this. There are also a principle of justice, which means we need to not only make research accessible to people, but we have to make sure that we don't place undue burden on a certain group of individuals because of convenience. We also want to make sure that if we learn something from the research, that it's generalizable to the people that have the most need for that new knowledge. So in the regulatory legal lane, it's really looking at what kind of regulations that we have that guide research practices, conflicts of interest, intellectual property, privacy laws. These are all things that are very regulated in research that is conducted at traditional academic research institutes, not so much for research that's being carried out by the tech giants that are now getting much more involved in health research than they ever have been before. So I'm really interested in traditional research and how these digital tools are used and how the regulations apply or don't, but also how we really are in a wild west of sorts when it comes to how research with humans is carried out when it's not regulated and there are no laws to keep up with it. And the social bucket is things about how do these technologies influence behavior, influence social groups. What are the privacy expectations when we can know things that we could never have known 10 years ago just because of the pervasiveness of the technologies that are being used? What are the downstream impacts? And one of the examples that just comes to mind quickly for me when I think about this is Cambridge Analytica, how that was, quick surveys, psychological surveys using Facebook to deploy it. Could be relatively benign, but we all know that the outcome of that was anything but benign. So with the digital health snapshot, and before I get too far ahead, what I want to tell you about this what I'm talking about is going to, I'm just going to give you basically a foundation for what we're going to do in the workshop. So I'm going to talk for about 45 minutes and then break for about 15 minutes where we can talk as a large group before putting people into these breakout groups where we're really wanting to have all of you who are involved help us think through what the governance should look like, particularly around how the campus is developing strategies that are being used to mitigate, identify, and intervene with COVID so that, we can stay healthy and function as a university. So that's kind of the pathway that we're heading down today. So this is going to be really active discussions in our breakout groups. And I'm really looking forward to you participating in that part. So just for some context, the sources of data that we have access to today are so much more granular. There's so much more volume of data than we've ever had access to before. So in the past 20 years, we've been creating these electronic medical records. Those are now used, with machine learning to do predictive analytics on whether or not a certain growth on somebody's skin is a cancer, if it's a certain type of cancer. We have access to Twitter, we have access to Facebook data, and Twitter was being used about 5 or 6 years ago to predict outbreaks of the flu more accurately than the CDC could at that time. And so just taking language that people are using in their everyday posts and being able to analyze those posts to the point where you can do predictions on what's happening in a particular community. We have environmental sensors all over San Diego County that are telling us about air quality, but also about people's movements. We can access information about hospital admits to figure out where in San Diego County we have the highest incidence of anxiety and panic attacks. So the sources of data are incredibly diverse, and they're being used increasingly for the purpose of understanding not only individual level health, but population level health. And so some of the methods are common to all of us. I mean, our cell phones can be used and are being used to deploy surveys in real time. That's something that we call ecological momentary assessment. So rather than having to wait for somebody to come to a lab or to do observational research or to deliver an intervention in a lab setting, we can now use these ecological momentary assessment approaches to find out how somebody is feeling in real time, ask questions about the extent to which they have exercised that day. Depending on the nature of the resource, these types of surveys can be deployed to capture any kind of data. So that's one example of a mobile method. What got me involved in digital health research from the get-go was the wearable cameras that were being used to see how people behaved in their everyday life, using a wearable camera that could be anchored to a lanyard and then just worn around the individual's neck. The thing is if I'm a research participant and I choose to participate in a study that's using a sense cam or a photographer, I can agree to participate. I mean, it's a relatively, it's just a small device that I put on this lanyard. But what got the interest of the Institutional Review Board, which is the body that reviews research with human subjects, is the idea that this could capture people that are around me and what extent did they have the right to privacy. And could their data be used for research purposes when they had never consented to participate in the study? But these cameras are being sold. You can buy one yourself. They were initially created by Microsoft to help people that were experiencing dementia remember what their everyday life was about. So they were created for research purposes. They're used more now by people that are doing self-study where they want to keep track of everything that they do in their everyday life. But for researchers of behavioral medicine, they wanted to use this kind of tool to see what people did, how active they were, how sedentary they were, without having to ask them questions. So it's just a really nice objective way of capturing data, but you all have to think through about, what could go wrong here. And even though we give them instructions on how to use it, they oftentimes would wear it when they were at the bank, putting in their PIN number, in the bathroom, in their home. I mean, in places where we would warn them, you should probably turn this off or put it away. They didn't always remember they were wearing it. And so these kind of tools have created some problems in research. Sensing methods, this is like an 1 by 1.5 inch sticker that you put on your skin, and it can capture really, really valuable information about heart rate, temperature. It has been used with women who are expecting to capture fetal heart rate. And, so it's got an amazing potential, but it's also got to transmit information, personal health information. How does it get from that sticker to a mobile phone, to a physician's office, or to a researcher? So these are just really fascinating new technologies that are coming out that we really don't have a good basis or foundation for. How do we think about the risks, the benefits, the data management? And all the while we're developing these research tools, we've got new data platforms available that are being used for research. So digital epidemiologists are increasingly using data that are being collected by these different apps like Runkeeper to see how people are moving through their environment. Another one is called Strava. There are just thousands of tools now available for use in health research. So with these new methods come new types and granularity of data. So whereas this camera you can see on the left is just worn by this person around their neck, it's capturing information about their movements, what they eat. And for research purposes now, if I'm studying nutrition and I ask this person to self-report what they're eating, I can look to see how close to accurate what they say they think they're eating is to what they're actually eating. So it's a tool that can be used for objective observation. The GPS is in the second cell, where you can see this is just a device that was being worn around the waist on a belt, but it would track where people went in their everyday life. And what was fascinating to me at the time is that the granularity of these data that were being captured could show when a person left their home, where they dropped off their kids, when they went shopping. And it was really interesting that the IRB did not have any concerns about GPS data. And this is, again, the board that reviews research with human subjects to make sure that they're protected from harm or that the risks are mitigated. Didn't seem to think that GPS tracking needed any special attention. And the volume of data in and of itself needed to have quite a bit of special consideration with respect to where do you store it. And then smartphones, all of you that have one, that whether you're wearing a watch or some kind of app, your smartphone is a key to capturing volumes of data that can be used for health research. And social media, I think it was James Fowler on our campus that was able to use Facebook data and friends. If he could identify the likelihood of obesity just based on 3 of your friends on Facebook. So at the point that, we got started on this research, it was about a year later that Fitbit came out. And since that time, there's wearables everywhere. And what I think has really been interesting is that the terms of service that we all know nobody reads, and if you did read them, it would be really hard to understand. They have language in their terms of service that directly conflict with the federal regulations that we need to follow to do research with human subjects. So that's been something that is very slow to change. The Fitbit is used in studies all over the world, and yet their terms of service conflicted with our federal regulations up until last year when they finally made a change to their terms. but only for researchers. And so what we've been doing over the past probably close to 4 years is developing tools that can help researchers, that can help institutional review boards, and that actually could be used by any one of us to make decisions about things that we choose to use for ourselves personally, or in making a decision of whether to participate in research. And we anchor these, and this was all driven through researchers wanting to have some direction in how to make decisions. And so we went through an iterative participatory design process where this framework was created through that process. And so what we learned is that ethical principles were needed at the core. The ethical principles that were used were those that were very much accepted in research, in health, behavioral, and biomedical research, which I've mentioned before: respect for persons, beneficence, and justice. And then we added respect for law and public interest, which was developed by cybersecurity experts working with the Department of Homeland Security, who really were forward thinking in 2012, saying that because all of the different types of infrastructure being developed that would make, cities operate effectively, they could be harnessed for public good, or for surveillance of publics. And so they came up with a set of principles that aligned with respect for persons, beneficence, and justice, but added respect for law and public interest. And so the 4 domains that we use are privacy, accessibility and usability, data management, and risks and benefits. When we talk about access and usability, we are thinking about how the product is designed and whether the end user is able to use the tool. So we want to know how it works. We want to know how information is communicated to the person that they intend to have use it. So for a researcher, it would be, how would we communicate information to a research participant? That happens through an informed consent process. But we also have to make sure that researchers are aware of what's in the terms of service, so that they don't choose a product that could, because of the terms of service or the privacy agreement, be harmful to the person who might participate in the study. And when I'm talking about this now, I'm thinking more about how the digital contact tracing might work on campus, other types of surveillance like the wastewater, and I'll introduce both of these things in a minute, but digital contact tracing and wastewater testing are 2 of the strategies that are being used in our return to learn protocol that are being deployed as of this week. Wastewater started about a month ago. The digital contact tracing was launched this week. Both UCSD and UC San Francisco were authorized to pilot the use of an app that you can download to your phone and opt to be involved or not. And so the other thing, so I'm thinking that this checklist can be useful as you're thinking about what should UC San Diego be thinking of with respect to how do they test usability and access. And do you have access? How is it being communicated with you? In order to use the app or be involved in the wastewater testing, do you need to have any special tools like a smartphone or internet access? And can this be something that's used both short-term and long-term? And so on the right side of the screen, you can see that this is how we organize a lot of prompts to ask yourself, or a researcher would ask themselves, or an IRB would ask themselves, what do I need to think about before I make a decision to use this tool? So the first domain is access and usability. The next one is privacy. And with privacy, we're thinking about the personal information collected, the expectation of the person who has maybe some value about keeping information to themselves. So with the domain of privacy, we want to know what is collected, what is shared, why is it shared, and what control do I have over data that are captured about me. The risks and benefits, this is a domain that we're really trying to evaluate the types of possible risks. So types, what we're talking about, is the risk a physical risk? Is it psychological? Could it potentially pose an economic harm or a reputational harm? So that's what I mean by types of harm. And then once we identify what the type of harm is, the next question is, well, how severe could it be? How long might it last? How intense is that potential harm? And then we also want to take a look at anything to do with how artificial intelligence is being used, and if it's being used, is it transparent? Are there accountability checks in that technology so that we can make sure that how it's making decisions is based on a data set that, we can't get rid of bias in data sets, but we can at least be aware of what the biases are and try to manage those. And so assessment of risk and benefit in a research study doesn't mean you have to get rid of all the risk. You have to be able to identify what the risks are, identify how you can minimize risks, and then evaluate whether or not the risk is reasonable in relation to the potential for benefit. And the benefit doesn't have to be a benefit to an individual. It can be a benefit to society or to people that are like those who are represented in the research. So this is where we really want to support how do we evaluate risk. And when it comes to a product that is being used in digital health, we want to make sure that the product, unless it's being evaluated in the research for determining its reliability and validity, we want to make sure that there's some evidence that we can find in the published literature that testifies basically that this product does what it says it's going to do. And think through what the potential unknown risks are, with that being reasonable risks, not the risk that, you might trip on the steps, but more, can we imagine what the risks are? And would those risks potentially be all the same for everybody? Or could it be that maybe one of our employees is at more risk than a student? And so I think we need to, imagine what would this risk be, and would that vary depending on the individual? Data management is a really big area. When I think about what I'm talking about is when we collect data, we have to identify what are the data that we need to collect, how are we going to collect it, once we collect it, where do we store it, is that storage secure, how do we make sure that it's in a secure place, and then how, if data are being shared with anybody, how are they being shared? Where is it going? Who has access? And do I have any control over any kind of data that is that is collected from me? The interoperability is more about, can I share data that is collected from a commercial product with my healthcare provider? And is there an easy way to make that so that there's that transition and I don't have to be in the middle of it? So those are the 4 key domains, and I introduce those again because I think that it will be really helpful when we do our breakout session to think about what are the risks and benefits, access and usability, privacy, and risk-benefit assessment. And many of you who are involved in technology development have probably heard the move fast and break things philosophy of, let's just get this built and we will iterate on the road as we deploy and we'll see how it goes. And Omidyar Foundation had an article in Medium about a year ago that I really resonated with me, because they were really thoughtful about wanting to make sure that they don't do societal harm in the development of technologies. And so their thinking was, well, how do we move purposefully and fix things as we're trying to head down this pathway? So now COVID-19 and return to learn have really moved us fast into this new area of how do we manage public health with technology. And so this article that I have up at the top that Jennifer Radden led over at Scripps is titled Harnessing Wearable Device Data to Improve State-Level Real-Time Surveillance of Influenza-Like Symptom Illness in the United States, a population-based study. So they were able to access data collected from wearable sensors and do predictive analytics on the spread, surveillance and spread of influenza, which came out just in January of this year, or February 1st. And I was preparing for a talk that I was giving at the National Academies on what are the bioethics of our future? What are the things that we should be thinking about? And I was on a planning committee for that, and we were really thinking about how are these tools being used, and the fact that they're not just being used by academic researchers, they're being used by health tech startups, they're being used by tech giants, they're being used by citizen scientists, do-it-yourselfers. It's just really opened up the ability for anybody to have access to either individual level or population level data. And so as I was preparing for that talk, I was reading these articles that had just come out in Science. So cell phone tracking could help stem the spread of the coronavirus. Is privacy the price? And that hospitals turn to big tech companies to store and analyze the data. No uniform standards for preventing misuse of patient data. So this is all happening before the pandemic really got launched. And I think this was around end of February, right before, because I gave my talk on February 24th. And right before that, this came out. We're living through a real-time experiment on balancing private and public health. I wish it weren't taking place during the pandemic. And this study is basically a partnership with the University of California, San Francisco, and Aura, which is a company that creates a ring that you can see in the palm of that hand, that I wear one every night. It captures my heart rate, my body temperature, respiration, heart rate variability, my sleep patterns, REM sleep, deep sleep. And I use it to do self-study for myself, but now they can capture the data from anybody who chooses to be in the study, who already has an Aura ring, to see whether or not they can detect signals that could be indicative of COVID. And so in this study, 2,000 emergency medical workers were wearing the ring for that study. So it was really early tracking of potential signs of COVID. And then this article came out in, I think it was, where's the date on this one? I think it was March, early March, about how quantifying Sars transmission suggests epidemic control with digital contact tracing. And the idea that, you know, using a digital signal that maybe is, you know, on my phone, it can identify, have I been around somebody that has recently tested positive and been in proximity, so where it would be calculated that I had been exposed. And then without violating the identity, the privacy of the person that may have tested positive, can I be notified that I've been exposed and given some guidance on, should I be tested? Was I close enough to where I just need to, you know, stay home for 3 or 4 days, or do I need to quarantine and get tested? So this was one of the first articles that was talking about digital contact tracing. And you know, that's something that's being used on our campus. And so it was launched from the news media. I saw that it was supposed to be rolled out this week. And, you know, the overarching goal of the Return to Learn program is to mitigate risk, and that's being done. These are the three pillars. Mitigate risk through cleaning and sanitation, face coverings, physical distancing, and structural reconfiguration. So that's all to do what we can to stop exposure. And then we're also deploying viral detection. So testing of asymptomatic and symptomatic. If you're a part of UC San Diego, you've received the notifications about what testing options are available. You probably also received the notification about the wastewater testing. I'm not familiar with what the county surveillance is, so I won't try to speak to that. And then intervention is if you are identified as somebody that is positive, how do we isolate that case? How do we do contact tracing? Traditionally, contact tracing is very much a part of public health. I mean, it has been around forever. It's how people learn who has been exposed and trace it back and try to identify not only the source, but who was around that source. The digital contact tracing is really to augment an already established traditional manual process where people who are positive are called. You collect information about where they've been, who they've been around. But the thing about that is it relies on memory. And I don't always remember where I've been, except for nowadays I don't go anywhere, so I kind of do. But in general, if we were doing our everyday things, we would have been around a lot of people. Now, the digital contact tracing is going to be, I think, more objective because it's just going to pick up these signals, but it could have false positives or false negatives. And so we don't really know how accurate it is. And I think that's maybe one of the questions that's being asked during this pilot. So this is the This was something that Chris Longhurst shared last week at the UCSD town hall, talking about how the state public health and technology leaders, Apple and Google, announced 2 pilot projects about using the platform that Google and Apple agreed to develop together for exposure notification. And so this is completely voluntary. They use privacy preserving, anonymous, automated exposure notifications so that if I'm in the vicinity and there is a signal that shows that I was in the vicinity for a long enough period of time to a person that tested positive, that I would be notified. And I don't know exactly what the process is for this pilot, but that's going to be part of what we talk about during the workshop. Like, how should we be involved, and what would we want our leadership to be thinking about? What are our concerns, and how would we manage those concerns moving forward? And so the new kind of testing, and this came out just about 2 weeks ago, UCSD is testing sewage for COVID-19. Turds tell tales, and UCSD is listening, which is the notification that we all got a couple Fridays ago, where it said, if you've been in this vicinity during these days at these times, you may have been exposed, that their testing of wastewater detected COVID. They knew kind of the parameters for when that happened. So they said, anybody who's used the toilets in this area needs to get tested. And so they did testing. They identified 2 employees that were asymptomatic. And so in thinking about, did this work? I think it was a great test where they were able to identify that people were positive. What kind of concerns are there around doing this kind of testing? What should we know before moving this forward? How does the community of UCSD want to be involved? All of this is new, as I mentioned, so ethical considerations to guide the use of digital proximity tracking technologies for COVID. Interim guidance just came out May 28th of 2020 by the World Health Organization. And they have I think it's 19 or 20 guiding principles and actual practices that need to be followed. And, what I wanted to say about that is, one of the principles is that we need to have community deliberations. There needs to be civic involvement in the process of identifying what this protocol should look like in order to make it acceptable to the people that will be involved. So digital contact tracing will only work if our community volunteers. There is no way possible for it to work if you don't volunteer. So that's something that, and I don't know how many people have been involved in the discussion around this. I know that there have been, people that are involved in privacy and healthcare and epidemiology are probably involved, but I'm not sure how others in our community have been involved. I come from public health. I've worked in community health for, 20 something years, 30 years. I have been in San Diego County. I think we have one of the most incredibly diverse counties that I've ever experienced. I mean, we have, Latino, Native Hawaiian, Pacific Islander, refugee. We live on a border. I mean, it's just an amazing place to be. And I got involved in community engaged research and what's also called community-based participatory research years ago. When we talk about it from an education standpoint, they may use the term participatory research. Human-centered design is more of a design phrase. These are all strategies that are to engage the public. In community engaged research, it's like I could observe a problem or see something that's going on, but I would never try to solve that problem without asking people in the community if this was a problem. And if it was a problem for them, how would they want to go about solving it? So that's engaging the community in the research. Community-based participatory research is maybe more about the community identifying the problem. Maybe they say our kids are getting asthma at a rate that just seems to be, over the top. We don't know why our kids are getting sick. They partner with a research team to say, can you help us answer these questions? The research team then works with this community authentically to help solve this problem in a way that's culturally appropriate, that is respectful. And you can't do that without a lot of conversation, because this is a relationship. You're not just going to swoop in and fix it and then take off and never be a part of this again. This is a long-term investment. Participatory research is what I've been doing for years. Like we tried to answer a question about how do we help digital health researchers do ethical and responsible research, because they told us, we're worried that we're going to do something wrong. We don't know what we don't know. And we can't be sure that the Institutional Review Board will know what we should be looking out for, but we don't want to do something that harms a person. So how do we come up with a way of collectively creating a resource? So they asked these questions of us, and then we said, okay, well, let's go and find out. We talked to a lot of IRBs. We talked to researchers all over the county, all over the country, basically. And we synthesized all of their information to say, here's what you're telling us. Is this what you think will work? And that's what was the origin of the Connected and Open Research Ethics Platform, which is a learning community that we have created that brings together digital health researchers, regulators, legal scholars. And, so it was through their comments that we created this resource. And then public deliberations and deliberative democracy is another way of convening the public to ask them questions about just, what do you think about how should we govern ourselves? How should this look? And typically it can be random people, but it can also be very intentional selection. Typically with public deliberation, it can be up to 4 days where you learn about everything that's going on. So one of the situations, in one case that I know of, it was stem cord blood. It was wanting to take cord blood and do some genetic testing. And so in order for the public to tell the researchers why this might matter, they had to understand what it was to begin with. So you have to take time to educate. In our case, it would be educating our community about wastewater and microbiome and and digital surveillance. And how does that happen? How would you know about where I am at a given particular time? You know, how does my phone pick that up and tell somebody else my location? So the whole idea is that you tell people what it is first. So there's a big chunk of education, and then there's deliberation on how do we do this in a way that's going to be respectful and acceptable, because only then can you actually scale a protocol. Otherwise, if you don't have the community's input, you won't know how it's going to be received. And so this is where we get into our breakout. And before we do that, I want to open up to our group. And I want to ask you all some questions. So what I can do right now is I can stop sharing. I just want to check here real quick before I stop sharing. So this is going to come up. This is going to come up in a minute. So this is what you're going to be doing in your breakout. So before we go to breakout, I want to pull up, I want to stop sharing. So we're going to stop and we're going to open this up for questions. And I have some questions that I want to start with, but while I'm looking for my questions, does anybody have any comments or questions about what I've presented so far?
Hi, I had a quick question.
Okay, Victoria. Do you go by
Oh,
Victoria?
yes. I was just wondering, how would digital tracing impact more underprivileged communities without access to smartphones or internet connection? Like, how would this play out in those kind of communities? Because I feel like this is based on the assumption that everyone has access to uh, advanced technology.
Yeah, it's a wonderful question. And when I think about the framework that I introduced, access and usability is a key part of that. So if it's only going to work on an iPhone, that presents a problem for people that only have an Android. If you have to have a smartphone to be included at all, it might exclude a large part of our community. I don't know how our community is set up in terms of the demographics, who has an iPhone versus who has an Android versus who doesn't have either. So that's a great thing that we would need to know first in order to know whether this pilot is potentially exacerbating a health disparity.
Hmm. Okay, thank you.
These are the kind of questions, I mean, we may not have the answers right now,
Hmm.
but these are the kind of questions that we really need to start writing down. And, you know, part of the working group, the breakout session, is going to be diving in on some of these. We've set up some very specific questions about planning, about facilitators, barriers, and then action plan. So this is an opportunity for you to start contributing, but for us to also think about how can we move this forward so that our community has that voice.
Hmm. All right, thank you so much.
Yeah.
Camille, that was a great presentation. I have just a sort of terminology question for you. You used the word objective a few times, and I was just wondering if you could give us a little more detail about what that term means to you in terms of objective knowledge through these tools, or give us an example of objective versus non-objective.
Thank you, Lisa. Yes, so in the behavioral research and possibly also in biomedical research, we rely on self-report. And so we do survey research. We can bring people into a lab setting. Now, when we first started doing the study that involved the wearable camera, the participant was also asked to wear an accelerometer and a GPS device. And so the study was actually triangulating whether these tools could objectively measure what somebody was doing. Now, the alternative is we can ask somebody, how active were you today? And somebody could say, well, people tend to inflate their activity and then they underreport what they eat. So we're relying on subjective data. The person's telling us what they recall or what they want us to know. So objective measurement is these tools can pick up what's actually happening. So in one case, there were cyclists that were enrolled in the study, and the GPS could tell that that person was moving. The wearable camera could tell that that person was moving, but the accelerometer showed that that person was sitting down. And you are typically sitting on a bike, but it on its own, the accelerometer would not have picked up what that person was actually doing. So it would have led to faulty assumptions. Does that help?
Absolutely, thank you.
So a question that I have, just for thinking about our group, what do you see as the possible barriers to access? So Victoria raised a question like, access to phones. Are there any other barriers to access that you can envision?
Hi, I'm Susan. It's not only the access to phones, so I think that one question that would be relatively easy to do would be to just when they're coming on campus, everybody has to fill out a bazillion forms. Do you own a smartphone? Doesn't matter which one. But do you carry your smartphone with you all the time? Because I don't think that's I think we're making the assumption that if you have a smartphone, that it's always on your body every second of the day. And for some people that may be true, but for others it may not. So that would be one of my questions. I think the barrier is going to be the fear of privacy is what you're going to run into, as I'm sure you know.
Okay. Yeah, so how people are using whatever the technology is could minimize accuracy. So I think that's something that's really important to think of. What other risks of harm are there potentially to a study like this? And actually, I shouldn't even use the word study, although I think I want you to think about, is this a study? So with the digital contact tracing, they talk about this is a pilot. And I think if you were to look at the privacy language that is associated with the terms of use, which are connected to a UCSD app that you may have downloaded to help you with location of where you need to go from class A to class B, or what class am I taking next, it'll show up on your app. So you've downloaded an app that UCSD is managing. And it's been great, it's been convenient. So now this new technology for digital contact tracing is deployed using an app that you may already have. So you can activate it, or you can download the UCSD app and then have access to this. But in the privacy language, there's a statement that says that this data collected using whatever they're collecting on this app could be used for research purposes. So there's the potential for any kind of data that are collected to be used for research. I'm curious about whether or not there's any additional type of informed consent that would be appropriate to ask or to present at a time like this. So so when you think about possible risks of harm, and there was a really great article that came out about a month ago that somebody wrote. It was published in Higher Education, and the question was, would an IRB approve this study if it went before an IRB? And yet this is not considered a research study. It's considered a service, a product that you can access similar to any other app that you download. You just need to accept the terms and conditions and you have access. So is there anything else you'd need to know? See, if it were reviewed by an IRB, they need to tell you about how it works, how long data are kept, who has access, what are the risks, what are the benefits. So all of that would need to be disclosed, and it would need to be disclosed in a way where you really have access and you understand what is being done. So do you have any thoughts about informed consent with respect to anything that's happening with the testing of wastewater, or wearing using a phone that has this digital contact tracing?
Well, there's always the potential concern that, say, the people who are collecting the data are my employer, and they may also be my healthcare provider, and those could be issues in terms of what that means for me as an employee and as someone receiving my health care from them, and what they do with that data. And that's always an issue with things like this.
Okay, so you're talking about a potential vulnerability where you normally wouldn't share information with your employer that you share with your healthcare provider. And how is that kept separate? And do you really have a choice? Am I hearing that right?
Yeah.
Thank you, Julie. Yeah. I think I've met you before, but I can't. Yeah.
Yeah, you've come to the CVD EPI meetings.
Okay, that's what I thought. Great. Well, are there any more questions? Because if not, I'm going to go ahead and move us into the discussion groups.
There is one question from Jonah Gray on the chat.
Yeah, I just put it in the chat there. I was just thinking it through as I was listening to some of these other comments. It's on a bit of a different sort of directory or direction than some of the other comments, but maybe related to Victoria's. And I was just thinking back to Benjamin's presentation, and where he talked about the sensing layer, which seems really apropos of these things like wearable technologies and phone contact tracing and that type of thing. And one thing that seemed really salient from his conversation was about weaknesses in the sensing layer that could be due to people refusing to be sensed, and that sounds like that would be in line more with some of the things that you were talking about. People are taking a decision not to be sensed, but then that there could be, and this to me is the biggest thing, as a Canadian in California, and one of the things I've thought about a lot relative to that is people who are undocumented, which make up a massive kind of presence, but also kind of like a invisible in the sense of kind of documentation in terms of all of these different things, probably also in a lot of ways not having medical insurance, which is also true of people who of course have documents as well in big ways in the US. But I'm just thinking about that, because then you have if it's elective, then you have this really weird thing that you may be leaving out such a huge mass of the population. And in the case of a pandemic, like this is such a huge, like you need to know whether, what the deal is with people, even if they're not officially being rendered or being sensed.
Yeah, so what you're bringing up is so important because adoption is critical. And there are so many things that could influence adoption. And one of them is trust. As Julie was bringing up, how do I know that my data are not going to be used in a way that could potentially harm me? And what are my rights as an employee? Can I truly say no, or might I lose my job? I mean, those are a lot of things. There's a lot of layers. Access to medical insurance. What if I have it and I don't have any care? Well, we have a lot of temporary employees. I certainly don't know what their healthcare status or choices are. Our temporary employees have a different setup, and I don't have the information of what that is, but I'd certainly want to hear from them before I figured out how will this work? Because adoption, first of all, you have to have enough access to testing to where digital or traditional contact tracing can happen. And right now with the public health department, people are making phone calls. Unfortunately, many people were not getting testing results for 14 days. So then you get called and now you can't remember who you were with 14 days ago or the week before that. So, I mean, the whole thing depends on adequate testing. I think UCSD has that in place now. So if we have testing, then how do we get this digital component? And I'm also curious about how you see the wastewater tracing. I had to ask the microbiome lead of American Gut Project, Rob Knight, can you actually identify somebody from the poop samples? Can you actually from that figure out who it might be? And you can, because there are unique signatures to COVID. And he was saying you can, if you know what the strain is, you can figure out maybe where it came from. So it's not going to be a direct match. So Julie, do you have any understanding of that? You're much more of a medical, you have the epidemiology base that I don't have.
He actually talked to our group just a couple weeks ago, but we didn't ask him about, can you figure out specifically? I mean, I guess what I do know is if you have a sense of what an individual's flora are, what their populations of microbiota are, you can probably match fairly well, but you would have to know each individual's to be able to match it against from what he was telling us.
So I don't think that that's a risk,
Yeah.
but it kind of reminded me of how HIV has a signature. And so you can actually identify where that, where somebody's infection may have come from. So anyway, it just got me to thinking about that. So
I think the wastewater is a little more problematic with informed consent because how are you able to opt out of that? So all of the concerns that you raised are, you're saying, well, you're opting into the digital testing. You're not opting in to your poop going someplace that's getting tested. So I think the informed consent is a challenge, and I don't think as much as tracing it to, I'm a physician, as tracing to an individual. I'm certainly no microbiologist, but I think that would be harder to do, but unless depends if you're sampling each toilet as opposed to a pipe that's coming from a building. I don't know where they're doing their sampling from. So that would inform me more about how specific's getting. So I do have, my question to you would be, where are they sampling it from? The building or a person or a toilet, one toilet, every toilet on campus, or is it a building pipe, bigger pipe on campus? And then how do you do informed consent when people just happen to go to the bathroom as they run by?
So I'd have to go back and read this protocol, but I remember seeing that robots would be picking up samples in specific bathrooms, but also they have what are those big manholes called? So they were going to be testing, and I'm not going to be able to describe this well. Julie, did Rob talk about how they were going to be testing?
Understanding is that it's more at the level of the pipe and the building or the region rather than it is at the level of the individual toilet or even the individual bathroom.
So I don't know. Yeah, I know that there were robots involved with some sampling in bathrooms, but this was going to be at the pipe level. They were talking about upstream and downstream, and so lots. Anyway, when you bring up the consent, and I don't know that it's individual consent, maybe more community consent, but also, how do we plan this is just such an interesting, I think it needs to be a community plan, but that's my bias, and that I really think communities are important to making something successful. but I'm going to let you break out into your groups. And what we've done is identify, so we really want to get an idea about how students think, how staff are thinking, and how faculty are thinking about this. And so we've created groups that are based on that hat. You don't have to be one or the other. You just want to take on the role. If you're assigned to the staff group, think about what a staff member might be thinking about. And I think about, landscape cashiers, people that are, managing our facilities, custodians, and then faculty and students. And so Noah and Danya and Miriam are going to be the group leaders in each of these breakout rooms. We have a set of questions. I'd like somebody in the group to identify as a recorder and a reporter. So one person that's going to take notes, and our 3 team members are going to give you a Google Doc where you can type notes in. But we've got this broken out into planning, facilitators, barriers, and next steps. So we're going to take about 30 minutes, and I think what you can do right now, Stephanie, is just move us into breakout groups, and then we can get started and return back here at 2:40, unless you finish up sooner.
Perfect. I am just creating them now.
And thanks for your questions. This is I just think this is such an interesting opportunity for the UC San Diego community to really inform a protocol that not only can be acceptable here, but that could be acceptable to other universities. I mean, we're kind of leading the way here, so it would be great if we did have a community process. Oh, here, wait, what happened to Noah?
Stephanie, I have to. Should I go?
Yeah, I figured out I did it manually, so you're all good to go.
Perfect. See you later.
Bye. Okay.
Thanks for doing that.
Yeah, I was like, ooh, I have special technicalities.
And is that a real bookcase behind you?
It is. We have the problem that I can't really use these things because it makes my hair look so funny. I look like Marge Simpson. Look.
Oh, how funny.
Speaking of the sensing layer, it just doesn't sense the side of your hair.
It's too fringy. Yeah. So
do you guys want to be a part of either one of the groups? How many people are in each group? Is it like 3?
Right now there's 4, including so 3 others than our guests. I have to stay here because otherwise.
Yeah, I can dive into one too. I think I'm signed up for 2. Is that a good one to go into?
Yeah, exactly. Camille, you're in 1 if you want to go, and Jonah, you're in 2 if you want to go.
Now, am I able to pop around?
I can pop you. So if you leave the
back from 1, I can go into 2.
Yeah, I can move you. I'm like command and control.
Awesome.
Exactly.
How do you think it went so far?
I think it's going good. Yeah. Cool. Yeah, I'm thrilled to actually be talking about facts and how things work. Not like the fiction is still there, of course, right? Like, I mean, in the question of what do we have to believe or suspend our disbelief to participate on some dimension in any of these studies. But yeah, it's exciting.
Yeah, I just think that, like I said, I couldn't have imagined. I mean, this would have been a true fiction that I couldn't have come up with a year ago.
Exactly.
Like, so bizarre.
Yeah.
And yeah, like, so, I was telling my aunt the other day, I said, I can't believe I'm writing a proposal right now about community governance of poop surveillance. because what I'm doing right now is really what I wrote as aim 3 for a proposal that just went in last week for the wastewater surveillance. And so they're doing it now, but our aim is to engage the UC community broadly. And how should this look? So this whole workshop is a trial for basically how would this look if we deployed it in a bigger scale.
Awesome. That's the best way to do it.
Yeah. Okay. So it's
Yeah.
2:12, and I said that we would come back at 2:40.
Okay.
And so when you give them, we can't communicate, or can we, to them, like I know one thing is if you're about to close it off, it says you have 1 minute.
I can broadcast, no, but I can also send a message to everyone. So I should probably were you thinking like 10 minutes before, just reminding them of the time, or?
Yeah, I think so. And I, again, don't know how much people will talk about each one of these areas. And I hope I gave them enough of a grounding to think. It seems like that's what I wanted to check with the larger group is, are you thinking about questions that you have, which seems like they are. So I think we should be good at 2:40 with maybe a 5-minute advance, like we're going to shut down in 5 minutes instead of 1, because 1 oftentimes just goes by too fast.
Oh, that 1 minute is crazy.
Yeah.
When you're in there, you're like, why? Yeah, okay, I'll send that warning.
Yeah, how did I go to group 1? Because I put later. I just said I would join later, and now it's gone.
You should do. Does it? Can you? Do you have like a little more button on your screen where maybe you can just? I think if you could just click that, you can go. But I can't see what you see.
No, I can only see mute. I have 3 little dots that say stop video, mute my audio. No, I don't have a way of joining. I think you would have to reassign me.
This is so weird because it says, well, can I move you to 3 first then? That I can do.
Okay.
Okay. Then it should, and now, do you see something? Nothing comes up?
No, but it's actually okay. I can just work on my catching my life right now.
Okay, that's fine. Fair enough.
Right, I'll put myself on stop video, and then I'll mute, and just tap me if something comes up.
Will do. Sounds good.
Like laid out in the space? Are these people that should be involved in this decision? When should we involve them? Because they're supposed not to be there. Like they're not supposed to be hanging out in school, but that is de facto happening. Finally, how might we engage the stakeholders? Yeah, maybe kind of like keeping up the communication, demonstrating how data collection can enhance safety through town halls, emails, but also being very aware and getting feedback if these kind of like forms of communicating things are actually having the effect the program wants. Like it's not just like checking a list within a town hall, because there is a lot of kind of like people are not very happy with the town hall. Sometimes their questions are not picked. Sometimes they feel they don't understand, that is very top down, that is very kind of like health and physicians oriented or students oriented. So are these working? Like, you know, like we are sensing the the virus, but we can also sense how much trust is like happening. Finally, yeah, how might we increase awareness? Well, in this point, we actually discussed that the big issue is like the best thing or the bigger benefit might be that we all stay at home. We did discuss that, and that is something that a lot of people do kind of like feel. And finally, for the barriers, fear of disclosing personal information, preconditions, other kind of stuff, the fact that it's clear that we are not all on board with this pandemic thing, and there are a lot of deniers. So how will that kind of like affect? And also testing its availability and accuracy. The fact that I might not want to be don't want to be exposed, but also I don't want to expose somebody else because I might be asymptomatic and there's no way I can get tested on time. Yeah.
Thank you, Veronica. Who is from the is it the faculty group we're doing next? Student stakeholders. So who's on the student group?
That was Amelia and myself, and I think Kate had to leave.
Okay, yeah, I don't see Kate here.
Yeah, so let me find my screen and share it.
And Kate is also working with Lily Arani on some of these questions, and so we can share some information about their study if anyone's interested in more dialogue, but we also will be convening and using your information here to kind of shape what we do next. So yeah.
I want to disclose I'm also part of the study, I'm sorry.
Okay.
I'm a researcher too.
Okay, good. Thanks for letting us know. So that you're working with Lily then. Okay. Lisa?
Yeah, okay, so Noah led our group, and basic governing principles, further information from R2L personnel and administration about informed consent, and more transparency about privacy, data usage, rationale, and motivations for policy changes, better understanding of rights and options relative to adoption, accessible communication, transparency, clarity about uncertainty. Who should be involved? Excuse me. All students individually. Kate made the point that having student leaders from, for example, GSA, doesn't always, the organizations are not always representative. And for graduate students in particular, it's very important to have individual students have the capability to be involved in discussions. How might we engage the stakeholders? Again, creating more transparency about process and including students and other stakeholders noted above in the conversation during deliberation, acknowledging that students are researchers and are, that it would be necessary to engage them in research's process as opposed to trying to appease or involve through enticements. How might we increase awareness of potential benefits, share more research and data rather than sell it, again. Barriers, privacy, data management, risk of discrimination, stigma, which were suggested as options were all relevant. And recommendations lay out clearly the kind of risk you expose yourself to in sharing data would go a long way. The devices are not always functional, address this. R2L personnel should share more research and data with stakeholders rather than sell it was a big point.
This is really fantastic, and I want to thank all of the groups. What we will do as part of our team is we'll synthesize your notes and basically put together a summary and share that back with you all. But I'd really like to also, at that point, get some permissions to share this with leadership so that we can start taking some action that is demonstrating respect, addressing the issues of transparency and accountability and all the things that we need to do to create a campus climate that people feel safe and comfortable in. So we will be back in touch. And until then, I want to thank Stephanie and Jonah for creating this design fiction series, and to all of you who have participated, and for those of you here today for contributing to our discussion. So thank you so much.
Yeah, thanks everyone. And thanks again, Camille and Julie, Caleb, everyone, Lisa, everyone, Jonah, of course, everyone who's been with us for this series. It was really an awesome experiment, and we'll look forward to your feedback. We'll send some feedback, and hopefully remain in touch about this, what you want to see more of, how to get involved with the design lab going forward. We should all keep the collaboration going and the conversation. So thanks a lot.
Thank you, Steph. You did a great job leading this.
Thank
I
you.
just put an email in there. So if you guys want to keep in touch with us on this, please feel free to reach out, because we'd love to have this conversation continue.
What's the best way to get, I'm probably already on the design labs email. Is that, like, if I'm getting them now, will I keep getting them?
Yeah, yeah.
Okay. Cool, cool. I've had so much fun. Thank you. This has been really insightful and so dynamic. Every week is like kind of similar, but it's so broad and broadening. So thank you all.
Thank you, Stephanie. You did a fabulous job coordinating this.
Well, it's been a total pleasure. Thanks to everybody. Have a great time. We'll see you for the next round.
Such an exciting talk, Camille. I look forward to more conversations.
Thank you so much. Take care, everybody.
Bye, everybody.
Thanks, everyone.
Thank you. Bye-bye.
Thanks, Sonia.